Well, good morning. Thank you very much for this invitation to visit Vietnam again. Very happy with the arrangement. What a great group. My disclosures are pertinent to the talk that I first administered cerebrolizin in 1989. I'm dating myself, but that was when I was first resident in neurology. Let me just, there is a, I think it's a wrong slide deck. I apologize for that. Yeah, it is a wrong slide deck. Let me bring my computer, okay?
Yeah, okay.
Mm-hmm. All right. Thank you very much. And so let me start by saying that in the first part of the talk, we'll review latest advances in clinical trials for stroke. So the key is that over the past couple of decades, we transitioned from a non-contrast CT scan, just non-contrast CT scan, to additional tests such as CT angiography and CT perfusion and multimodal MRI, and made our patient selection more sophisticated. And so why did we do this? Well, first, we wanted to focus on who benefits most from reperfusion therapy. Again, think about departure from intravenous thrombolysis, which was the best option for most patients in any level emergency room. But for that, you just need a CAT scan and an IV infusion. But now we have mechanical thrombectomy. And so mechanical thrombectomy needed to demonstrate the benefit. And selection was made beyond the CAT scan by demonstrating first occlusion and second, some kind of favorable perfusion scan. And we did these trials since 2014. There were a number of trials that extended the indication for mechanical thrombectomy up to 6 hours, then up to 24 hours of unknown. And after we did all this, the question was, why did we exclude these patients? We excluded patients with very large cores, depicted here as red, 100 cc's. That's a presumed very large core, and a very small mismatch. So the latest trials of large core trials focused on the patients previously excluded from mechanical thrombectomy. And these are 6 trials that were reported. These are abbreviations. And also they differed somewhat in selection. Some were aspects, some were based on core estimation. But regardless, they attempted to enroll patients who were previously ineligible. And so as a result, and I'm showing you guidelines from the Society of Vascular and Interventional Neurology, summing up these 6 trials of large core infarcts, that if you have the patient arriving within the first 6 hours regardless of what aspect shows, regardless how big the core is, this patient needs to go and get mechanical thrombectomy done. Because leaving these large clots and big strokes unattended, you're greatly increasing chance of patients dying or laying down bedridden. Now, once you roll out between 6 and 24 hours, selection of patients becomes more important, but then look, the only patients that we don't know if they benefit or not are patients with like super large cores, which is aspects of 0-2, or really, really large core with very little a mismatch. So that is the lowest evidence that we have. But everybody else with aspects 3 or greater, up to 24 hours or onset unknown, essentially becomes mechanical thrombectomy candidate. So what it means for us in practice, that when you see a patient, regardless of time, you need to think about a possible treatment. Early on, it's systemic thrombolysis, but at an extended time window, call the center that has neuroendovascular capabilities. So at the same time, as we were doing large core trials, our endovascular colleagues became enthusiastic about going after medium vessel occlusions or smaller, like further branches, M2, M3, and so forth. And so I cannot show you all the details right now because it's easier to just summarize it through meta-analysis and refer you to this most recent publication. It is a open access publication. I'll show you the summary of these trials. But the bottom line is our tools that were developed for large vessel occlusion are not yet nimble enough to go very distal. And so there were a lot of complications. So you can see here, these are 3 trials, DISCOUNT, DISTAL, and ESCAPE MEVO, that basically all showed that in terms of symptomatic hemorrhage rate, there is definitely a risk of causing more bleeding if you go with a catheter that is not suited for very small vessels to go and try to open it up. And if you look at favorable outcome, or good outcome, I should say, modified Rankin score 0-2, the allocation group in these clinical trials favored best medical therapy. Okay, so that was kind of a cold shower. And if we go back to this particular publication, I like the quote, the opening quote that they came up with. Life is not about how many times you fall down. It is about how many times you get back up. And so this cold shower of MEVO trials in stroke right now is very reminiscent of Honolulu shock of 2013, when 3 trials came out and they were negative because our tools were not suitable for the problem. So if you remember in 2013, endovascular trials were negative for 2 reasons. Number 1, we did not use CTA for patient selection. Okay, so we did not know where occlusion was in these trials. And second, our tools were ancient. I call them Stonehenge, like in England, okay? So Stonehenge tools, it was a kitchen sink, not until stentriver was invented. So stentriver allowed us to establish mechanical thrombectomy, but stentriver turned out to be a wrong tool to go after M3 because they are not designed for M3 problem. So we need to change the technology, and Tang is here, and he's constantly trying these things. So we're proposing now a trial of MEVO using aspiration only, and select a specific catheter that would be most suitable and gentle to go after these lesions because they are prone to bleeding. So technique is very important. All right, so having said that, what other advances we had recently to improve safety of our reperfusion therapy. So my colleague from Kazan in Russia, Dina Hasanova, conducted this trial called Serehetis, where all patients were receiving thrombolysis with TPA, and half were receiving cerebrolysin right at the time of initial reperfusion, and then in a standard dose for 14 days compared to standard of care. So this is their publication. They randomized 341 patients. It's a sizable trial, and what they found was a significant reduction of any hemorrhage on repeat imaging, as well as symptomatic hemorrhage rate went down from 9% to 2.6%. And that was a significant finding. Since it was a pilot study, they didn't know how to power 90 days outcomes. They observed a very favorable trend that not only they improved safety of IV TPA within the standard window, but they also saw a trend that more patients recover completely or nearly completely at 90 days, and with a trend for per protocol of reduction of the most severe strokes, like modified Rankin score 4, 5, and 6. In parallel with that study, our colleagues from Poland completed WIM study, W-I-M, WIM study just published in Translational Stroke Research. What they were interested is to test early administration of cerebrolysin with mechanical thrombectomy. Now, they didn't randomize for one reason or the other, but they found age and stroke severity matched controls within their institution. And so their hypothesis was to see if 3 weeks of cerebrolysin initiated at the time or shortly after of mechanical thrombectomy will make a difference in safety and stroke outcomes. So to evaluate efficacy of cerebrolysin as an add-on therapy to endovascular therapy and rehabilitation. So not only they gave it acutely, but they also extended it for the first 3 weeks, where patients transition after thrombectomy into rehab. And so what they saw was that groups were evenly matched, and then there was a trend towards early neurological recovery, and also there was a very favorable trend in terms of improving outcomes. That's a lower graph here, modified Rankin score 0, 1, and 2, and to an extent 3, if you think about modified Rankin score of 3 as a worthy endpoint after fighting large vessel occlusion. So the trend was seen in the right direction across all modified Rankin score strata. So these two recent trials actually lend even more credibility to transitioning in our thinking from neuroprotection. As you know, we tried for close to 3 decades different types of neuroprotective agents that were designed to specifically turn off one particular mechanism in this complex ischemic cascade. And over 1,000 approaches were tried, $1 billion was spent, and we have no neuroprotective single agent because the problem was more complex that a single molecule can do. And so here is the publication by Pat Lydon, one of the leading researchers in neuroprotection, who basically said, let's abandon the term neuroprotection because the problem is a lot more complex than a single neuron. For example, neurons are surrounded by glia. They are fed by neurovascular unit. The brain acts as a whole, so you want to design a polypotent, pleiotropic, multi-target agents that can address the brain need as a whole. And interestingly, when we looked at cerebrolizin, cerebrolizin is one, if not the only molecule out there, well, it's a collection of molecules, that actually meets every target on this diagram. So if you put at all components of cerebrolizin, they are acting everywhere that is on this wish list, first of all. And second, they act in time proportionately to the brain need. So if acutely you want to preserve blood-brain barrier integrity and minimize the risk of bleeding, we have data for that. If you want to reduce inflammation, there are data for that. And if you want to aid rehabilitation, I'm going to show you what we have. And so these are different approaches into that. So not only you protect your cells first, but then you aid neuro restoration. And one of those rehab trials that was done differently from what you may have seen in the literature is the trial called CARS. So how is it different from other trials? Well, like with stroke therapy, when we were designing our first trials, we were very non-selective. And when you go non-selective in terms of your patient population, you need to conduct very large trials to see very minuscule differences. The alternative approach, like what was done with mechanical thrombectomy, to super-select patients to focus on the ones who really need your therapy and who are more likely to benefit from it. So this is what was done in this particular trial. So patients were selected for the visit that started between 2 and 3 days from symptom onset. So 2 or 3 days from symptom onset is a very important time because acute treatment is done, and usually after 24, 48 hours with repeat brain imaging, we can say, this guy is going to do well and going to go home. This one is not going to do well at all. But this one needs rehab, right? And so approaching the patient within the first 3 days, selecting them early, and starting therapy. Then the next question is, in whom can you demonstrate rehabilitation benefit most? And it turns out that there is a NIH stroke scale score is a very long score. It contains many, many things. But there is ARAT score, A-R-A-T, ARAT score, that focuses predominantly on the function of the arm. And if you have very minimal effort in the arm, this is the person who should benefit the most from rehab, because regaining dominant hand, for example, is very, very important to return to the quality of life. And that's whom they focused their trial. And then they had several visits. And here, as you can see, their time. So the visits were, after baseline was 7 days, 14 days, 21 days, and then follow-up was close to 90 days. And so here's the baseline ARAT score. So the lower the number, the worse the function. And you can see that it was a moderate stroke. NIH stroke scale score was 9. So even if you tried reperfusion therapy, if you're still about 9, you need rehab, right? All right, and so what they saw was they randomized patients to same rehabilitation, but half received cerebrolizin daily for 3 weeks, and half were receiving standard of care and no cerebrolizin. And what you can see here, that improvement in ARAT score was noticed in both groups. Here's control, and here is the target. But in the target group, the improvement occurred much faster, so they progressed much faster, and they reached much higher level of function. So I think that was, and not only the benefits that is seen on already first follow-up visit in 7 days, but it also is sustained over. And as a result of that super selection, same theme, like mechanical thrombectomy. Remember, the smallest trial of mechanical thrombectomy that showed the benefit was 75 patients, Extend IA, right? So even in this rehab, targeted rehab trial, they saw that 42% 42% more patients ended up with no significant disability just because they regained the function of the hand. That is very, very important. And so it was followed by CARES-2 when they did it in multi-center fashion. They did also a meta-analysis that I would refer you to if you look into all the studies that were done. This was noticed by a review in Lancet Neurology, Advances and Challenges in Stroke Rehabilitation. So 14 out of 15 trials done in the past decade were negative. Technology neutral, PTOT combination neutral. In fact, I was just attended World Stroke Congress, yet another trial, European Stroke Organization Conference, another tailored rehabilitation trial in Australia was negative. And pharmacological aid to standard rehab with cerebrolizin, these were the positive trials. So that produced inclusion into national guidelines. So Austria, Canada, Germany put highly ranked this evidence, and particularly said that it is very important in upper extremity rehabilitation in patients with moderate to severe strokes. So those who are surviving and will be leaving hospital with disabilities. That is the focus. And I appreciate your inviting me once more time. Thank you, organizers. Thank you, Mr. President.